Hi everybody, welcome to this session in lower limb. It's about femoral triangle, a very frequently asked essay question in your theory examination. Apart from that, for your practical exam also, a lot of structures here can be pointed out as your spotter questions, okay? And of course, image-based questions, case scenario, they keep coming up in your competitive examination. I'll read this case scenario for you. A 21-year-old Mrs. Chaitra presented to surgery OPD with complaints of swelling over front of the right thigh. So what could be the reason there? We have the femoral artery, the femoral vein, the femoral nerve, we have inguinal lymph nodes, right? Okay. She also added that she had fever for past 5 days. Fever is a symptom that manifests when there is some infection or inflammation within the body. Backache. Why backache? Difficulty in walking due to the presence of a swelling that is in the front of the thigh. On examination, a cystic swelling. So the consistency of the swelling is of course very important, right? Whether it's hard, soft, cystic. Was noted below the inguinal ligament. This is another important keyword. Yes, if a swelling is going to be located above the inguinal ligament or below the inguinal ligament, it gives a very important clue for your diagnosis. And below the inguinal ligament, in front of her right thigh. Blood tests and radio imaging studies confirm the diagnosis of psoas abscess, secondary to tuberculosis of spine. Psoas major muscle that you get to see is in the posterior abdominal wall on either side of the vertebral column. What is it doing in the lower limb in the front of thigh? And tuberculosis of the spine of the vertebra. Maybe that was the reason why the patient had backache. Okay, so it's like different pieces in a puzzle, right? We are going to put it together. So a swelling in the front of thigh diagnosed as psoas abscess. So how that psoas major in the abdomen going to be related to the lower limb? Let's have a look into femoral triangle. The boundaries of the femoral triangle, where is it located? What are the contents of the femoral triangle? And also in detail about the femoral sheath, its compartments and contents, okay? So all these structures related to femoral triangle, we'll be having, yes, a quick revision, okay? Femoral vein, femoral artery, femoral nerve, each can be a short note to you. And then the inguinal lymph nodes also clinically important. The lateral femoral cutaneous nerve and the femoral branch of genitofemoral nerve, they are also related to this femoral triangle. Of course, fascia lata, did you appreciate it in the cadaver? Where is it present? Over the lateral aspect of the thigh. The fascia lata is the deep fascia of the thigh and it presents certain modifications, especially the saphenous opening, which is related to the femoral triangle, and the thickening of the fascia lata over the lateral aspect of the thigh called the iliotibial tract. Okay, this iliotibial tract can be important spotter question for you. And femoral sheath, again, another important short note. So in this session, we are going to talk all details related to these structures. Shall we start? Come on. So where is this femoral triangle? So this is an image of the thigh. Can you appreciate here? This is the femoral triangle. Where is this femoral triangle present? Of course, in the front of thigh. To be even more specific, this is a triangular depression that you see in the front of the thigh, in the upper 1/3 of front of thigh. Okay? And it is present beneath the deep fascia, that is the fascia lata. This one here, extending from the I'll mark it here, from the antro-superior iliac spine to the pubic tubercle is an important landmark called the inguinal ligament. This femoral triangle is situated below the inguinal ligament. What is this inguinal ligament? So, yes, this is the region of the anterior abdominal wall where we have three flat muscles from outer to inner, external oblique, internal oblique, and then the transverse abdominis. the external oblique muscle, it forms the upper neurosis as you see here. Okay, this upper neurosis, its lower border is thickened and inturned to form the inguinal ligament that extends all the way from the anterosuperior iliac spine to the pubic tubercle. So, our femoral triangle is situated in the front of thigh, upper 1/3 of the front of thigh, below the inguinal ligament and deep to the fascia lata. Okay, come on. Coming to the boundaries of the femoral triangle. So, this is the medial aspect and this is the lateral aspect. Okay, so this is the medial border, the lateral border, the apex below, the base above. Medial border is formed by a muscle of the medial side of the thigh. Any idea what it is? Yes, the medial border of adductor longus. And then we have a lateral border formed by the medial border of sartorius. Apex is the point where these two borders meet. Base is formed by the inguinal ligament. There is a roof and a floor. So these are the boundaries of inguinal ligament. Now, moving to each boundary. So what you see here, this muscle is the adductor longus, a muscle in the adductor compartment or the medial side of the thigh. We have adductor longus, adductor magnus, adductor brevis. We also have pectineus, gracilis and obturator externus in this compartment. The nerve of this compartment is obturator nerve that comes from the lumbar plexus. So the medial border of adductor longus, it forms the medial border of femoral triangle. Coming to the lateral border, it is formed by the longest muscle in the body, sartorius. The lateral border is the sartorius. Its medial border forms the lateral boundary of this femoral triangle. Sartorius is the longest muscle, okay? It arises from the anterosuperior iliac spine. It goes all the way up to the tibia. It is related to the hip joint as well as it is related to the knee joint, innervated by the femoral nerve. The apex, as I told you, is the point where the medial border and the lateral border meet. Yes, beyond the apex, we enter the adductor canal, which is situated on the middle 1/3 of the medial side of the thigh. The contents from here will enter there, right? And the base is pointed above. It's formed by the inguinal ligament. Yes, can you tell me what is this inguinal ligament? It is the thickening of the lower border of upper neurosis of external oblique. What is its extent? Anterosuperior iliac spine to the pubic tubercle medially. Coming to the structures in the roof of the femoral triangle, it is formed by skin, superficial fascia. So in the superficial fascia, we'll get to see the cutaneous nerves, isn't it? And then also the superficial veins of the lower limb. And then we get to see the deep fascia. The deep fascia, as I told you, it's called the fascia lata. And we have seen the modifications of fascia lata, the saphenous opening iliotibial tract. Here, the femoral triangle will be related to the saphenous opening. So let's have few details about it. Come on. Coming to the cutaneous innervation of thigh, it is important. So this is the medial aspect, this is the lateral aspect. Okay, so you should at least remember the name of the nerve and a few important points related to it. Okay, so what you see here, this one, yeah. So this green color is the region of inguinal ligament, right? Just related to the medial part of the inguinal ligament, we have the inguinal canal. And this is the superficial inguinal ring. What you see coming out is the spermatic cord. The spermatic cord in the male has the vast difference, the blood vessels, the nerves to the testes, okay? Whereas in the female, the inguinal canal is traversed by the round ligament, okay? So this spermatic cord is going to reach the testes. It is going to be surrounded by one muscle also called the cremaster muscle. Now, exiting out of the superficial inguinal ring, we have the ilioinguinal nerve. The ilioinguinal nerve, it traverses the inguinal canal. It exits out of the superficial inguinal ring. And where do we get to see it now? In the thigh, in the upper medial side of the thigh. Am I right? Please remember, it is coming from the lumbar plexus with the root value L1. Okay. And below that, this one here is the cutaneous branches of the obturator nerve. The obturator nerve, what are the three compartments in the thigh? We have front of thigh, medial side of thigh, and back of thigh. In the front of thigh, the huge muscle there is the quadriceps femoris, which extends the knee. Hence, it is called the extensor compartment. And the nerve of the extensor compartment is femoral nerve. Similarly, medial side of the thigh, we have the adductor muscles, which can adduct the thigh. And these are innervated by obturator nerve. So, obturator nerve is a nerve of the adductor compartment, medial side of the thigh. This is also coming from lumbar plexus with the root value L2, L3, L4. Okay. So, branches from this obturator nerve, we see it over the medial side of the thigh, supplying the skin there. And again, here lower down, this is the medial femoral cutaneous nerve. It is a branch coming from the anterior division of femoral nerve. Femoral nerve is again from lumbar plexus with the root value L2, L3 and L4. Okay, so the branches of this medial cutaneous nerve of thigh, they are the anterior branches, posterior branches. They supply the lower part of the medial aspect of the thigh and also go ahead to supply the medial aspect of the knee and the upper part of the medial side of the leg also. And branches of this medial femoral cutaneous nerve of thigh, especially its posterior branch, will contribute to the subsartorial plexus. Where do you find? What is the subsartorial canal? The other name for adductor canal, which is found over the middle 1/3 of the medial side of the thigh. Okay, contribution from the medial cutaneous nerve of thigh to the subsartorial plexus. And lower down here, it is a branch from the saphenous nerve, the infrapatellar branch of the saphenous nerve. Please remember, this saphenous nerve is very, very, very important. It is the longest cutaneous nerve in the body. Okay, so this saphenous nerve, it comes from the posterior division of femoral nerve, right? And this saphenous nerve, it is there in the femoral triangle. We'll also get to see it in the adductor canal, and then it will pierce the roof of the adductor canal. It will extend along the medial side of the knee, the leg, and also in the dorsum of the foot up to the ball of the great toe. That is why it is called as the longest cutaneous nerve in the body. And yes, so along the medial side of the thigh, supplying the skin, we got to see the ilioinguinal, obturator nerve, medial femoral cutaneous nerve, and the saphenous nerve branch, right? This one here is the intermediate cutaneous nerve of thigh. Again, it is a branch coming from the anterior division of femoral nerve. So in dissection in the cadaver, you can very well make out that these intermediate cutaneous nerve, they pierce the sartorius muscle. Here, you can identify the saphenous opening there, right? This is the great saphenous vein. The great saphenous vein is passing through the saphenous opening to enter into the femoral vein, isn't it? And close to that, can you appreciate this nerve here? Yes, that is the femoral branch of genitofemoral nerve. We'll be talking more about it, okay? Femoral branch of genitofemoral nerve. So it will lateral to the femoral artery, lateral compartment of the femoral sheath. It will pierce the femoral sheath and supply the skin over the femoral triangle. So that could be an MCQ for you. The skin over the femoral triangle is innervated by femoral branch of genitofemoral nerve. This genitofemoral nerve is again coming from the lumbar plexus with the root value L1 and L2, right? And more important, clinically important, which they keep repeatedly asking in your competitive exam, this nerve that you see here, yes, running along which aspect of the thigh? This is lateral, this is medial, isn't it? This nerve that you see here is the lateral cutaneous nerve of thigh, again coming from lumbar plexus L2, L3. Okay, so this nerve, it passes, this is the inguinal ligament, right? So it has to enter these branches of lumbar plexus, they are in the abdomen, posterior abdominal wall. So whatever we have seen now, it has to pass from the abdomen into the thigh, and this lateral cutaneous nerve of thigh, it passes behind the inguinal ligament, just medial to the anterosuperior iliac spine. All of you can feel the anterosuperior iliac spine, right? You would have felt it in the cadaver, just medial to it. So behind the inguinal ligament is the lateral cutaneous nerve of thigh, reaching the thigh. Okay. So we have seen about the nerves supplying the skin of the front of thigh, and we saw that most of them are coming from the lumbar plexus. Can you enumerate what are the branches of lumbar plexus here? Yes, the ilioinguinal nerve, then we saw the obturator nerve, then the femoral nerve, yes, and genitofemoral nerve, lateral cutaneous nerve of thigh, isn't it? All of them from the lumbar plexus. This could be important MCQs for you. That's why I'm stressing on it, okay? Ilioinguinal nerve root value L1. Obturator nerve and femoral nerve share the same root value L2, L3, L4. Genitofemoral nerve L1, L2. Lateral cutaneous nerve of thigh L2, L3. Then my next question, what were the branches of cutaneous branches of femoral nerve you saw in the front of thigh supplying the skin? Yes. So from the femoral nerve, we had, come on, from the anterior division, yes, medial cutaneous nerve of thigh and intermediate cutaneous nerve of thigh. One more, the longest cutaneous nerve in the body, but coming from the posterior division of the femoral nerve. Yes, very good. The saphenous nerve. So, TK? Yeah. Now, coming to one important applied anatomy about this. So, the skin over the lateral aspect, isn't it? Over the lateral aspect of the thigh is supplied by this lateral cutaneous nerve of thigh. With the root value L2, L3, yes, it gives anterior and posterior branches. The anterior branches will supply the anterolateral aspect of the thigh, and the posterior branches from the lateral cutaneous nerve of thigh, it will supply the posterolateral aspect, including the gluteal region, a part of the lateral aspect of the gluteal region. Okay, and this you remember, the skin over the femoral triangle has been asked as an MCQ, is innervated by the femoral branch of genitofemoral nerve. Now what can happen is, sometimes this lateral cutaneous nerve of thigh, while it is passing beneath the inguinal ligament, just medial to the anterosuperior iliac spine, can get compressed, or it can pass between the fibers of the inguinal ligament to reach the thigh. When it is getting compressed, okay, the patient can present with pain, tingling, paresthesia, or in some case numbness along the distribution of this lateral cutaneous nerve, which is the area, the anterolateral and part of the posterolateral aspect of the thigh. This condition is called meralgia paresthetica. Okay, so this is one high yield topic. Now, another thing related to the cutaneous innervation of thigh. So I told you this is the inguinal canal. You see the spermatic cord coming out of it. And do you remember I told you there's a muscle surrounding it? The cremaster muscle. The cremaster muscle. Okay, it surrounds the spermatic cord. And where is the spermatic cord going? To the testes, right? So when this cremaster muscle contracts, this testes will be pulled upwards and occlude the superficial inguinal ring. Okay. So that is the function of cremaster muscle, and this cremaster muscle is innervated by genital branch of genitofemoral nerve, Just now we came across this nerve, right? Genitofemoral nerve, but the other branch of it, yes, come on, tell me. The femoral branch of genitofemoral nerve that innervates the skin over the femoral triangle. Okay, now we are learning about the other branch, the genital branch. The genital branch of genitofemoral nerve, it innervates that cremaster muscle that's going to pull the testes and occlude the superficial inguinal ring. Okay, there is one reflex called cremastric reflex. So when you go to the OG ward, okay, or pediatrics ward, you come across newborn babies in pediatric ICU. You just stroke the medial aspect of the thigh. Stroke the medial aspect of thigh. What will happen immediately is, reflex is something that's happening immediate, right? So stroking the medial aspect of the thigh, you can see the testes going up and occluding the superficial inguinal ring. This is called cremastric reflex. The afferent component of the reflex. Afferent, what do you mean by the term afferent? The sensory component of this reflex. So while stroking the medial aspect of the thigh, the upper medial aspect of the thigh, what was the nerve we came across? Come on. The ilioinguinal nerve, which was coming from the lumbar plexus with the root value L1. Okay, what happened immediately on stroking the upper medial side of the thigh? The testes, it went up by the contraction of the cremaster muscle and it occluded the superficial inguinal ring, right? So this is the motor component. And the nerve responsible for the contraction of the cremaster muscle and the movement of the testis towards the superficial inguinal ring is genital branch of genitofemoral nerve. The genitofemoral nerve has a root value L1, L2. So the cremastric reflex is related to L1, L2 segment of the spinal cord. This is again an important MCQ high yield topic for you, okay? So understand that, you'll remember it. Deep fascia modifications. We saw that the roof of the femoral triangle is formed by skin, superficial fascia with the cutaneous nerves. We have talked about it now. And then the deep fascia, which is called the fascia lata. The two important modifications of fascia lata is the saphenous opening, and the other one is on the lateral aspect of the thigh. Yes, the iliotibial tract. So the saphenous opening is related to the femoral triangle. It is oval opening, okay? And it is closed by the cribriform fascia. There are number of structures that enter and leave through the saphenous opening. So the fascia lata in that area is sort of tears, lot of minute holes there. That is why it's called as the cribriform fascia. Okay, so where exactly is this saphenous opening situated? How is it related to the femoral triangle? It is situated over the supromedial aspect of the thigh, right? So we know the femoral triangle is situated in the upper 1/3 of the front of the thigh. So we have the saphenous opening also in the upper middle side of the thigh. Okay, and its landmark is very important. So put your fingers over the pubic tubercle in the cadaver. Okay, when you go to your dissection hall in the cadaver, feel for the pubic tubercle. This saphenous opening, it lies 3 to 4 centimeter below and lateral to the pubic tubercle. Okay, so this landmark is very important. Okay, so to differentiate inguinal hernia and femoral hernia, this is going to be very useful. 3 centimeter below and lateral to the pubic tubercle. This is our saphenous opening. The upper lateral and the lower margin of the saphenous opening is very well defined, sharp. It's called the falciform margin. Whereas, okay, the rest of it, the medial border of it, it is ill-defined, and this ill-defined margin, it passes behind the femoral vessels or behind the femoral sheath. Okay, what are the structures related to the saphenous opening, passing through the saphenous opening? The most important one is the vein that you see here. Can you tell me what is it? The longest vein in our body, the great saphenous vein, right? And the tributaries, superficial epigastric vein and superficial external pudendal vein. Lymphatics and few branches of the medial femoral cutaneous nerve. They pass through the saphenous opening. Fine. Now coming to the next modification of fascia lata, very important, the iliotibial tract. So the fascia lata is the deep fascia of the thigh. Over the lateral aspect of the thigh, it is thickened to form the iliotibial tract. As the name suggests, okay, so it is attached to the margins of the iliac crest and then it splits to enclose two muscles that you see here. Okay, what are they? Come on. In the gluteal region, it receives the upper 3/4 of the insertion of gluteus maximus. And this muscle over the upper lateral aspect of the thigh is the tensor fascia lata. Okay, so the iliotibial tract, it splits to enclose these two muscles. And I'll tell you one interesting point here. Between the attachment, okay, enclosure of these two muscles, this part of the fascia lata which lies between, yeah, this is called gluteal upper neurosis. And you know what lies underneath the gluteal upper neurosis? The gluteus medius muscle is important because the intramuscular injections that we give in the lower limb, in the buttock region, is into this muscle. It passes through the gluteal upper neurosis to enter into the gluteus medius muscle, okay? And lower down, if we trace this iliotibial tract, it's going to the tibia, okay? There is one small triangular area in the front of the lateral condyle of the tibia, which is called as the Gerdy's tubercle, into which the iliotibial tract inserts. Okay, so you should be able to identify the iliotibial tract in the cadaver. Please look for the, yes, the tensor fascia lata muscle and also the gluteus maximus muscle, which are inserted into this iliotibial tract. Between the two, yes, that's the gluteal upper neurosis, and underneath it is the gluteus medius muscle. Its lower attachment, Gerdy's tubercle. All these are important MCQ spotter questions, right? Can you tell me what are the functions of this iliotibial tract? So this iliotibial tract is responsible for maintaining the extended position of the knee joint. Okay, extended position of the knee joint. It supports the knee during standing or walking. And more important, it is frequently used as a graft for any surgical repair to fill any defect in lower limb surgical procedures. Okay. Now, so we have seen about the boundaries of the femoral triangle. We were talking about the medial border, lateral border, the base, the apex, and then the roof we started. In the roof, we learned about the cutaneous innervation of the thigh, the saphenous opening, and few words related to the iliotibial tract. Now, moving on to the boundaries again to the tract, right? The floor, the muscles that lie in the floor of the femoral triangle. Can you identify 1, 2, 3, 4 labeled in this image? 1 is lateral, isn't it? And 4 is medial. Come on. 1 here is the iliacus muscle. And just, yeah, medial to it, you see it more green, more upper neurotic fibrous. That is the psoas tendon. And more medial to it, we get to see pectineus in the floor. This pectineus is a muscle in the medial side of the thigh. Adductor longus, seen next to it, that is also a muscle in the medial side of the thigh. Whereas the iliacus and psoas, they are coming from the abdominal wall, posterior abdominal wall to reach the thigh. Okay, so you shouldn't have a problem in identifying the floor muscles, which can be pinned in your spotters. Between the iliacus and the psoas tendon, we get to see, yes, the trunk of the femoral nerve. And between the psoas tendon and pectineus, we'll get to see medial circumflux femoral artery. This medial circumflux femoral artery is a branch of profunda femoris that arises from the femoral artery. Okay, and between pectineus and adductor longus. If you try to separate these two muscles, you can see something else is passing between them. Yes, the profunda femoris artery, which is the largest branch of the femoral artery. Okay, so in the cadaver, make sure you identify the floor muscles from lateral to medial, iliacus, psoas, tendon, pectineus, adductor longus. And please remember, this pectineus is a hybrid muscle. You see it in the front of the thigh as well as in the medial side of the thigh. It is going to be innervated by two nerves. It receives its nerve supply from the trunk of the femoral nerve, and being a muscle of the adductor compartment, it is also innervated by the obturator nerve. Fine? Okay. What are the contents of this femoral triangle? We get to see the femoral artery. Yes, here, and medial to it the femoral vein, the branches of the femoral artery, the tributaries of the femoral vein, and then lateral to the femoral artery, that's the femoral nerve, right? So the femoral nerve is the largest branch of the lumbar plexus. This femoral nerve, its branches also will be seen in the front of the thigh, right, in the femoral triangle. And apart from that, the femoral branch of genitofemoral nerve, yes, which supplies the skin over the femoral triangle, and part of the lateral cutaneous nerve of thigh, and inguinal lymph nodes. So inguinal lymph nodes, we classify them as superficial inguinal lymph nodes and deep inguinal lymph nodes. Which one do you think is related to the femoral triangle? Any idea? So while talking about, we started femoral triangle even and told you in the location, it is subfacial beneath the deep fascia. So here we'll get to see the deep inguinal lymph nodes. Okay, and the fibrofatty tissue. So these are the contents of the femoral triangle, and we are going to learn details about each content because it can be asked as a short note for you. So let us start with the femoral vein. Do you think you'll have a problem in identifying femoral vein either in an image-based question or in your spotter examination? Not at all. It is the easiest one to identify because of its location. Yes, it is the medial most structure in the femoral triangle. Okay, medial most, it gives a clue for you to write to identify the structure. Okay, so this femoral vein is continuation of popliteal vein. So the lower limb, yeah, upper limb, we saw that we have the pectoral region, the shoulder region, the back, the arm, the cubital fossa, the forearm, and the hand. We saw the palm of the hand, the dorsum of the hand. Similarly, lower limb, if you learn, yes, you'll be learning that it has a thigh, leg, foot, gluteal region, isn't it? And the foot, we learn it as dorsum and sole. At the junction of the arm and forearm, we have the cubital fossa. Similarly, lower limb at the junction of the thigh and the leg. On the posterior aspect, we have the popliteal fossa. Okay, so here we have the popliteal vein. And this popliteal vein is going to continue upwards as femoral vein. So from where to where? So the extent of this femoral vein is from the adductor hiatus. The adductor hiatus is the fifth opening in adductor magnus. So what is this adductor magnus? So I've been telling you, thigh, we'll be learning it as front of thigh, medial side of thigh, and back of thigh, isn't it? Okay, so in the medial side of the thigh, there's one bulky muscle there, the adductor magnus. We have adductor brevis, adductor longus, and adductor magnus. This adductor magnus is the bulkiest of all, and it has 5 openings. The fifth opening of this adductor magnus is quite huge, through which the femoral artery is going to continue as popliteal artery, and the popliteal vein is going to continue as femoral vein into the thigh. Okay, so from the adductor hiatus to the mid-inguinal point, What is this mid-inguinal point? Remember the inguinal ligament extending from the anterosuperior iliac spine to the pubic tubercle. Okay, so just more medial to the pubic tubercle. Okay, in the midline we have the pubic symphysis. So this is the anterosuperior iliac spine. This is pubic symphysis. Okay, a line joining the anterosuperior iliac spine to the pubic symphysis, and the midpoint of it will be the mid-inguinal point. At the mid-inguinal point, the external iliac artery continues as femoral artery, and the femoral vein continues. It extends further as the external iliac vein. This external iliac vein, yes, along with the internal iliac vein, it will form the common iliac vein. The right and the left common iliac vein together, they form the inferior vena cava. Okay, and that finally opens into the right atrium. So that is about the femoral vein. And in the femoral triangle, I told you it is easiest to identify because it is the medial most structure. And the upper 3 to 4 centimeter of this femoral vein and femoral artery is going to be covered by a fascial prolongation called femoral sheath. Okay, so we saw that in the upper part, this femoral vein is medial to the femoral artery, but in the lower part, okay, so during dissection in the cadaver, try to appreciate the relationship between the femoral vein and the femoral artery. In the lower part, the femoral vein will be actually lying lateral to the femoral artery. And then in the middle, you can see disappearing, hiding behind the femoral artery. And upper part, it comes to lie medial to the femoral artery. Okay? Any vein, if they tie the vein in the spotter, the question will be identify, give its extent or like formation, termination, and then tributaries, isn't it? So what are the tributaries of this femoral vein? The longest vein in the body, the great saphenous vein. Through the saphenous opening, it enters the femoral vein, isn't it? Apart from that, I told you the largest branch of femoral artery is the profunda femoris artery. So the accompanying vein, profunda femoris vein, opens into the femoral vein. And then the medial circumflux femoral vein and the lateral circumflux femoral vein. These medial and lateral circumflux femoral arteries are branches of profunda femoris artery. Okay, the corresponding veins, they open individually into the femoral vein. And the deep external pudendal vein, it can either open into the great saphenous vein or as a tributary of the femoral vein. So if the femoral vein is tied in the spotter and they ask for the tributaries, apart from great saphenous vein, please remember the profunda femoris, medial circumflex femoral, lateral circumflex femoral, and the deep external pudendal vein are also the tributaries of it. Okay, so you can identify the femoral vein here, right? So this is the femoral vein, right? The femoral vein. Opening into the femoral vein, this is the great saphenous vein. Before this great saphenous vein opens into the femoral vein, you can see it receives the three superficial tributaries, the superficial epigastric vein, the superficial circumflux iliac vein, and superficial external pudendal vein. Okay, this is the profunda femoris vein, the medial circumflux femoral, and the lateral circumflux femoral vein. Plus one more I added, the deep external pudendal vein as tributaries of the femoral vein. Come on. The femoral vein, the clinical importance of the femoral vein, yes, you can tell me. So the femoral vein, like it is, we have the peripheral veins in the upper limb, right? The median cubital vein we saw in the cubital fossa. And we have seen the deep veins in the upper limb. So this femoral vein is a deep vein, right? So in the cadaver, you might have seen it's used for embalming procedures. And then for intravenous infusion, okay, so especially in infants and children, you want to infuse a large amount of fluids and the peripheral veins are collapsed, we can choose the femoral vein. And in certain procedures, when you want to reach the right heart, we can put the catheter or the cannula through the femoral vein. So it will pass through the femoral vein, the external iliac vein, and then, yes, it unites with the internal iliac vein to form the common iliac vein. And the common iliac vein of both the sides, they unite to form the inferior vena cava into the right atrium, right ventricle, as far as the pulmonary trunk. Yes. And the other one thing that's very, very feared is the deep vein thrombosis. So in patients who have undergone any major surgeries or fracture of bones of the lower limb, or in paraplegia patients who are immobilized for a longer time, patient who don't like stand up and walk, okay, or do any physical activity, who are lying down for a long period of time, what can happen? There is a reduced amount of blood flow in the veins of the lower limb, right? Yeah. And this stagnation can favor coagulation, forming deep vein thrombosis, thrombus formation. And if this thrombus, it gets dislodged, it will enter the pulmonary circulation, pulmonary embolism. So we saw the route, right, from the femoral vein, how it reaches the pulmonary trunk. This thrombus, if it gets dislodged as emboli, it can reach all the way up to the pulmonary trunk to the lungs, leading to a serious fatal condition. Okay. So we've seen about femoral vein. Now let us move on to the next important content, the femoral artery. So this femoral artery, that is also easy to identify. So if you can figure out the femoral vein in the cadaver as the medialmost structure, just lateral to it, we'll get to see the femoral artery. And of course, the difference between vein and artery is very appreciable in this when you look. So the femoral vein, the wall is going to be more of thin walled, right? Whereas the artery is going to have nice thick wall. You can definitely appreciate that. So this femoral artery is a continuation of external iliac artery. From where to where we call it as the femoral artery? From the mid-inguinal point. Just now we saw, right, what is mid-inguinal point? The mid-inguinal point, it extends from the antero-superior iliac spine to the pubic symphysis, the midpoint of this line. The midpoint between antero-superior iliac spine and pubic symphysis is called as the mid-inguinal point, right? From the mid-inguinal point up to the fifth opening in the adductor magnus, that is the adductor hiatus, we call it as the femoral artery. And beyond that, we are going to call it as the popliteal artery. So here, yes, you can see the external iliac artery continuing as the femoral artery at the mid-inguinal point. This here, it corresponds to the adductor hiatus. And then you can see the femoral artery, it's going behind, related to the popliteal fossa, where we call it as the popliteal artery. And this popliteal artery at the lower border of popliteus muscle, it terminates into anterior tibial artery and posterior tibial artery. This posterior tibial artery, it continues over the back of leg and also into the sole as the plantar arteries. Whereas the anterior tibial artery, you can see in the front of leg. If you trace it further, it goes to the dorsum of the foot as dorsalis pedis artery to provide blood supply. So imagine something causing occlusion in the femoral artery. Then the blood supply to the entire lower limb is deprived of, right? Okay. So peripheral arterial disease, where we check for the pulse of the dorsalis pedis artery, right? It can be due to decreased blood flow. Especially in which of these patients it occurs is like in obese patient, in chronic smokers, in diabetic patients. Yeah, the peripheral arterial disease is important. Okay. So we can identify the femoral artery in an image-based question or in the cadaver. Now let us look into the relations of it, okay? So immediately medial to it, you can tell me it is related to the femoral vein. And just lateral to it, we have the femoral nerve, the trunk of the femoral nerve, okay? And what lies behind the femoral artery? Which floor muscle? Yes, the tendon of psoas major. It is separated from the tendon of the psoas major by the posterior wall of the femoral sheath and the nerve to pectineus. Okay, and close to the apex of the femoral triangle, this femoral artery, it is crossed from lateral to medial anteriorly by this medial cutaneous nerve of thigh, which arises from the anterior division of the femoral nerve. Now let us look into the branches of this femoral artery. So the femoral artery, it gives rise to the muscular branches that supply the muscles that we see in the front of the thigh. And then three superficial branches. Superficial epigastric artery, superficial circumflux iliac artery, superficial external pudendal artery, deep external pudendal artery, and then the largest branch of femoral artery which I have been telling you recently, come on, the profunda femoris artery. Okay, not related to femoral triangle. So I'll take a different color, okay. In the adductor canal, it gives off its last branch, the descending genicular branch of femoral artery. Descending genicular branch. Genicular, genu refers to the knee. So this descending genicular branch, it goes towards the knee joint. It anastomoses with the supromedial genicular branch of popliteal artery. Okay. So here you can identify the femoral artery, right? Yes, the muscular branches and then the superficial epigastric artery. You can see it going across the inguinal ligament upwards towards the umbilicus to supply the skin of the anterior abdominal wall, the lower part of the anterior abdominal wall below the umbilicus. Superficial epigastric artery. This one going upwards laterally below the inguinal ligament towards the antero-superior iliac spine to contribute towards the spinous anastomosis around the antero-superior iliac spine, right? And this one going medially, related in front of the spermatic cord, superficial external pudendal artery, going behind the spermatic cord, deep external pudendal artery. The pudendal refers to perineum, external genitalia, right? So the superficial and external pudendal arteries, they supply the perineum, the external genitalia. And then we have the largest branch coming from the femoral artery, the profunda femoris artery. Okay, so let us have a look into it. The profunda femoris artery, as I told you, it is the largest branch of femoral artery. It arises from the lateral surface of femoral artery. Okay, so this is the profunda femoris. Okay, and it arises 3.5 centimeter below the inguinal ligament. In the floor of the femoral triangle, we can see that this profunda femoris artery passes between which two muscles? Between pectineus and adductor longus. Further course, we can see it passing between adductor longus and adductor brevis, and then further between adductor longus and adductor magnus. Finally, it will pierce the adductor magnus, okay, and then it will end by anastomosing with the superior muscular branch of popliteal artery. So that completes the story of profunda femoris, but let us have a look into its branches. This profunda femoris artery, okay, this profunda femoris artery, it is going to give rise to few important branches, okay. So it will give rise to this lateral circumflux femoral artery. So in the upper limb, we have seen that we have come across anterior circumflex femoral artery, posterior circumflex femoral artery, winding around the corresponding surface of surgical neck of humerus, winding around, right? That's why these branches are called circumflux femoral, winding around the shaft of the femur. The lateral circumflux femoral artery is this one, right? And then this one here going more medially, that is the medial circumflux femoral artery. Okay. And then it gives off three perforators, the first, second and three. There are three perforators. And the termination of the profunda femoris itself, it continues as the fourth perforator. Okay. So what are the branches coming from profunda femoris? It can be tied in cadaver, right, in your spotter exam. Remember, the branches from profunda femoris are lateral circumflex femoral, medial circumflex femoral, the three perforators, and the fourth perforator is the continuation of profunda femoris artery. The lateral circumflex femoral artery is this one. Very important. Okay, so you can see that this lateral circumflex femoral artery, it passes between the two divisions of the femoral nerve. So we saw in the floor of the femoral triangle, the contents from medial to lateral, it was the vein, the artery and the nerve. The trunk of the nerve is very small. Very soon, it will divide into an anterior division and posterior division. And you can see the lateral circumflex femoral passing between the two divisions of this femoral nerve. It passes between the anterior division and posterior division of femoral nerve. Okay. And then branches from this lateral circumflex femoral, this one here. Okay, it is the ascending branch. This ascending branch of lateral circumflex femoral, it goes to contribute for the spinous anastomosis around the antero-superior iliac spine. And then you get to see a transverse branch, right? This transverse branch of lateral circumflex femoral, it will participate in the cruciate anastomosis. This cruciate anastomosis is situated in close relation to the lesser trochanter of femur, right? And this one here. Another branch, the descending branch of lateral circumflex femoral, it will go down, okay? It will contribute for the genicular anastomosis around the knee joint by anastomosing with, yes, the supralateral genicular branch of popliteal artery, okay? So apart from this ascending branch, descending branch and transverse branch, there's one more branch coming from this lateral circumflex femoral that goes for contribution for the trochanteric anastomosis. This trochanteric anastomosis, you can see it in the trochanteric fossa. No worries, we'll be talking about these anastomosis again, okay? The later part of the session. Now, let us look into the next branch of this profunda femoris, the medial circumflex femoral artery. You can see it spiraling around the medial surface of the shaft of femur, right? So, branches from the medial circumflex femoral, if you see, a branch that goes for contribution to the trochanteric anastomosis. Now, you can tell me where is the location of the trochanteric anastomosis in the trochanteric fossa. Okay. This trochanteric anastomosis, it forms the chief source of blood supply to the head and neck of femur. Okay, yeah. And apart from that, it will give another transverse branch. This transverse branch of medial circumflex femoral, it will contribute for the cruciate anastomosis. Can you tell me the location of cruciate anastomosis in relation to the lesser trochanter of femur? Okay, and there's one more important branch from this medial circumflex femoral, the acetabular branch of medial circumflex femoral. Okay, so what will happen? This acetabular branch, it will pass through the acetabular notch, which is bridged by the transverse acetabular ligament. It will go underneath the transverse acetabular ligament. It will reach the acetabulum to supply the acetabular fat there. And then it will traverse through the ligamentum teres femoris that will extend from the base of the transverse acetabular ligament to the fovea capitis, a depression seen in the head of the femur. So this acetabular branch will pass along the ligamentum teres femoris to reach the head of the femur to supply a very small area in the head of the femur close to the attachment of ligamentum teres femoris. Okay, so that was about the branches of medial circumflex femoral. Now let us move on to the perforators of profunda femoris. So totally how many perforators? 4. Of the 4, the first, the second and third are branches of profunda femoris artery, isn't it? Whereas the 4th perforator is the direct continuation of profunda femoris. Now, you can tell me, why are they called perforators? Because these arteries, they pierce adductor magnus, they pierce lateral intermuscular septa, and finally, they end in vastus lateralis. Okay, so this is the first perforator, the second perforator, the third, and this is the fourth. This second perforator, it pierces adductor brevis and adductor magnus, and more important, it provides the nutrient artery to humerus. Okay, yes. You can see the perforators here, the first perforator, the second, the third and the fourth. You can also appreciate each perforator is going to divide into ascending and descending branch, and they anastomose with one another. A chain is formed there, a longitudinal chain is formed there. Anastomosis between the branches of the successive perforators. This anastomosis, it provides a potential blood supply to the back of thigh. Okay, so for example, if you take this is the first perforator, you can see dividing into the ascending branch and descending branch. The descending branch of the first perforator is anastomosing with the ascending branch of the second perforator and so on, right? Okay, now this ascending branch of the first perforator, okay, these are all MCQs for you, okay? The ascending branch of the first perforator, it is going to contribute to the cruciate anastomosis. What is this cruciate anastomosis? It is an anastomosis that you see located close to the lesser trochanter. What are the arteries contributing to this cruciate anastomosis? We have seen the transverse branch of lateral circumflex femoral, the transverse branch of medial circumflex femoral, the ascending branch of the first perforator, and a branch from the inferior gluteal. Okay. Again, you can see it is going to be related to it close to the hip joint, supplying the femur and the hip joint as well as the front of thigh. Okay. So, cruciate anastomosis, where is it located? What are the arteries contributing? Okay. Similarly, if you see the last perforator, right, you can see that it has an ascending branch and descending branch. The ascending branch is going to anastomose with the descending branch of the third perforator. What will happen to its descending branch? It anastomoses with the superior muscular branch of popliteal artery. Okay. A word about the trochanteric anastomosis. It is called trochanteric anastomosis because you can see this anastomosis in the trochanteric fossa, this area. What are the arteries contributing to this trochanteric anastomosis? A branch from inferior gluteal, a branch from superior gluteal, branch from medial circumflex femoral, and a branch from lateral circumflex femoral. This anastomosis is very important. I've given you the reason. It forms the chief source of blood supply to the head and neck of femur. Now, yes, you can tell me what are the applied importance related to the femoral artery. Any artery, yes, it's pulsation, right? Come on, pulsation of the femoral artery can be felt at the mid-inguinal point. If you, yes, put your fingers over the mid-inguinal point and compress the femoral artery against the head of the femur. Okay. And also, compression of the femoral artery at this point will help to control any bleeding distal to the point. You can access the femoral artery for embalming procedures also. So most of you in your cadaver, like you must have seen a thread tied around the femoral artery or vein, right? For embalming procedures. Apart from that, yes, this femoral artery can also be preferred for catheterization procedures, yeah, to measure arterial pressure, to collect blood for arterial blood gas analysis. Okay, so this is done to assess the respiratory metabolic state of the individual, of the patient who's presenting with any respiratory disorders or in ventilator, patients who are on a ventilator for a long time, right? And then, as I've told you, peripheral arterial disease. Peripheral arterial disease, and who are the people susceptible to it? Chronic smokers, diabetic patients, okay, obese patients, due to atherosclerosis, which can reduce the, narrow the lumen of the arteries, decrease the blood flow through it. So that will decrease the pulse also, isn't it? To add few more clinical importance to this femoral artery, please remember it is preferred for angiography procedures. So what is this angiography or why is it done is that to identify a block in the blood vessel that supplies the heart, the coronary artery. So we insert a cannula into the femoral artery. It will pass through the external iliac, through the common iliac. It will reach the abdominal aorta. The abdominal aorta, if we trace it further, it becomes continuous with the arch of aorta and then the ascending aorta. And the coronary arteries are branches from this ascending aorta. So you can inject a contrast material and then identify the where the block is, okay, for angiography, angioplasty procedures. And last but not least, this femoral artery, compared to other arteries in the body, it is bit superficial, subfacial, beneath the deep fascia, right? So it is very susceptible to lacerations. Any trauma, injury over the front of the thigh can cut through this femoral artery. Okay? Yes. So far we have seen about femoral artery, femoral vein, the branches of femoral artery in detail. Now let's move on to the femoral nerve. Femoral nerve also easy to identify in an image-based question as well as in the cadaver because it is the lateral most structure, right? So this femoral nerve is very, very important. It is the nerve that you see in the front of thigh. Okay, so this is the largest branch coming from the lumbar plexus with the root value L2, L3 and L4. So the lumbar plexus, it actually lies within the psoas major I've been telling you the very first case scenario we started with in the introductory part of the session, right? A psoas abscess in the front of the thigh. So the psoas major is located on either side of the vertebral column, and within the psoas major, we get to see the lumbar plexus. And then the nerves emerge out from its border, either from the medial border, lateral border, or it can pierce to the anterior surface also. So this femoral nerve, it emerges through the lateral border of psoas major. We have seen that the psoas major, it lies in the floor of the femoral triangle, right? Okay, lateral border of psoas major. And in its further course, okay, you can see it lying, yes, just over the surface of this muscle there, sitting on the iliac fossa iliacus. So it lies on the surface of the iliacus, outer to or behind the fascia iliaca. And this fascia iliaca, will be learning soon that it forms the posterior wall of femoral sheath. Since this femoral nerve, it lies over the iliacus, outside the fascia iliaca, it is not included within the femoral sheath. It's not covered by the femoral sheath. It comes to lie outside the femoral sheath. It's not covered by the femoral sheath, okay? So, yes, in the femoral triangle, we see it as the lateralmost content, and outside the femoral sheath, it has a very short trunk that will soon divide into anterior division and posterior division. Come on, let me see who tells it correct. Which structure passes between the anterior division and the posterior division of the femoral nerve? Just now we saw, right, the lateral circumflux femoral artery passes between the two divisions of this femoral nerve. Okay, now what are the branches coming from the trunk of the femoral nerve? From the trunk, we get branches to iliacus, nerve to iliacus, nerve to pectineus. I told you the pectineus is a hybrid muscle. We see it in the front of thigh as well as in the medial side of the thigh. So it is innervated by femoral nerve as well as obturator nerve, and then vascular branches to the femoral artery. Okay, so these are the branches coming from the trunk of the femoral nerve. So in your practical examination for spotter, the trunk of the femoral nerve alone can be tied, and they can ask you branches from the trunk, isn't it? Coming to the anterior division of the femoral nerve, it gives one muscular branch, nerve to sartorius, and two cutaneous branches, the medial cutaneous nerve of thigh, and one more, the intermediate cutaneous nerve of thigh. Well, talking about the cutaneous innervation of front of thigh, we have seen about it, right? Posterior division of the femoral nerve, it gives one cutaneous branch, the saphenous nerve. And then it gives branches to supply the quadriceps muscle, the four components of it. Nerve to rectus femoris, nerve to vastus lateralis, nerve to vastus medialis, and one more, nerve to vastus intermedius. These are all the four components of quadriceps femoris, the largest muscle in the body over the front of the thigh. So this is the rectus femoris, beneath it vastus intermedius, medial to it vastus medialis, and lateral to it, this one is the vastus lateralis. All these are innervated by branches coming from the posterior division of femoral nerve. Okay, I would like to add few points related to the saphenous nerve. So you know the saphenous nerve, it comes as a branch from the posterior division of the femoral nerve. And I told you it is the longest cutaneous nerve in the body, right? So you see it in the thigh. You see the saphenous nerve in the thigh. If you further trace it, okay, it will be going to the knee, and then further trace it, you can see it in the leg, and also in relation to the ankle, and all the way up to the foot. Okay, So that is why it is called as the longest cutaneous nerve in the body. In the thigh, we get to see it in the femoral triangle. In the femoral triangle, okay, the saphenous nerve, it will lie lateral to the femoral artery. Okay, and then you will also get to see it in the adductor canal. In the adductor canal, in the upper part of the adductor canal, this nerve will lie lateral to the artery and then it will cross it anteriorly from lateral to medial. Okay, so the femoral artery is crossed by the saphenous nerve anteriorly from lateral to medial in the adductor canal. While in the adductor canal, a branch will arise from the saphenous nerve that contributes to the subsartorial plexus. And it will exit the adductor canal by piercing the roof. So we'll be talking about the saphenous nerve and adductor canal also. Okay, so please remember, it will pierce the roof of the adductor canal to exit it. Once outside the adductor canal, it will give one infrapatellar branch. Infrapatellar branch of the saphenous nerve that's going to supply the medial aspect of the knee. So it will be supplying the medial aspect of the knee. It is supplying the medial aspect of the leg. You can see it over the medial aspect of the ankle and also in the medial border of the foot. You know where it ends? Up to the ball of great toe. Till that, along the medial aspect, it is the saphenous nerve starting from the knee all the way up to the ball of the great toe. And it is closely over the leg, ankle and foot. It is closely related to the great saphenous vein. Initially, it will lie behind the vein. But, okay, lower part of the leg and over the ankle, it will lie anterior to the great saphenous vein. So, what are the clinical importance related to the great saphenous vein? This great saphenous vein is commonly chosen for cut down procedures, right? You want to infuse large amount of fluid, right? You can get it done through the great saphenous vein. Okay, and it is also used as a graft for bypass procedures. So any procedures over the great saphenous vein, this saphenous nerve can get accidentally injured and then the patient will have loss of sensation in the distribution of the saphenous nerve territory. Okay, so saphenous nerve is important for your spotter, for any case-based discussion in an image-based question. It is a high-yield topic. Okay, so we have seen about femoral nerve, where it comes from, what is its root value in the femoral triangle, its relations, the branches from the trunk, anterior division and posterior division. Okay, now applied anatomy of this femoral nerve. Yes, so injury to the femoral nerve. What is its motor component? Paralysis of which muscles? Yes, mainly the quadriceps femoris. This quadriceps femoris, I told you, it helps in extension of knee. So in patients with femoral nerve injury, they may not be able to extend the knee. So that will not be like he might have difficulty in standing or walking itself if you're not able to extend the knee. Another important muscle supplied by this femoral nerve coming from its anterior division nerve to sartorius. This sartorius is a very important muscle. We'll be talking about it in the next sessions. It arises from the anterosuperior iliac spine. It goes anterior to the hip joint and then it goes posterior to the knee joint to insert into the tibia. This sartorius, it flexes, it abducts and laterally rotates the hip, whereas it flexes and medially rotates the knee. Okay, so it is also called the Taylor's muscle. When you sit on the floor with crossed legs, it's called the Palti's posture, right? So when you sit, you can see that your thigh is abducted, laterally rotated, and the legs are, the knee joint is flexed and medially rotated. That's because of the contraction of the sartorius. In femoral nerve injury, this may not be possible again. Coming to the sensory component of the femoral nerve, yes, The branches from the femoral nerve, the cutaneous branches, the medial cutaneous nerve of thigh, the intermediate cutaneous nerve of thigh, and saphenous nerve. So sensation may be absent over the anteromedial aspect of thigh, the medial aspect of the knee, and along the saphenous nerve distribution. Okay. So here you can see a needle inserted not into the femoral nerve, just beside the femoral nerve. It's called the femoral nerve block. Okay, a type of local anesthesia, right? Regional anesthesia. So any procedure over the front of the thigh to get the patient relieved of pain, we can do a femoral nerve block. Fine. So this is again another picture to show you the femoral nerve block, and you can see that this is the femoral vein, the medialmost structure. This is the femoral artery, and outside the femoral sheath, more laterally, we have the femoral nerve. Okay, femoral nerve block can also be done under ultrasound guidance. So far in this session, we have seen about the contents of the femoral triangle, including the femoral vein, femoral artery, and femoral nerve, isn't it? Now we are moving on to another important high-yield topic, the femoral sheath and its clinical importance, femoral hernia. I'll read this case scenario for you. A 70-year-old Mrs. Maria, obese and known hypertensive, presented with a swelling in front of the left thigh. It had been present in her left groin for past 2 years. On examination, the doctor noticed that the swelling was present below the inguinal ligament, below and lateral to the pubic tubercle. This is a key landmark to differentiate femoral hernia and the inguinal hernia. If the swelling had been present above the inguinal ligament, okay, above and medial to the pubic tubercle, then it would have been inguinal hernia. On close examination, the swelling appeared globular with a small extension supralaterally, and it expanded on coughing. So it is having some communication with the abdominal cavity. The increase in intra-abdominal pressure during coughing, it causes that expansile impulse, right? And a diagnosis of femoral hernia was made. So a swelling in front of the thigh, below the inguinal ligament, below and lateral to the pubic tubercle, a swelling that has been present over 2 years, okay, and a positive cough impulse, right? It is all suggestive of femoral hernia. Now let us look into the anatomy of it. So what is this femoral sheath? It is a fascial prolongation that covers your femoral vessels. The upper 3 to 4 centimeter of the femoral vessels below the inguinal ligament. So you can make out the femoral vein, you can make out the femoral artery, right? You can also make out that fascial prolongation. Yes, it is sort of conical or funnel shaped, right? And this fascial prolongation, it merges with the tunica adventitia of these blood vessels, which it covers. This femoral sheath, the fascial prolongation, it is formed by the extraperitoneal connective tissue, which lies outside the peritoneum, right? Extraperitoneal condensation of the extraperitoneal connective tissue. And these vessels, they are continuation of the, like what you see in the abdomen, right? The femoral artery is continuation of external iliac artery, and the femoral vein is going to become continuous with the external iliac vein. So these vessels, they lie in the extraperitoneal connective tissue. They come with it. And the anterior wall of the femoral sheath, okay, the layer which lies just superficial to the extraperitoneal connective tissue is the fascia transversalis. So it will continue to cover the vessels into the upper part of the thigh, forming the anterior wall of femoral sheath, fascia transversalis. And the posterior wall of the femoral sheath, yes, you can see here, this is the iliacus muscle in the iliac fossa. And the fascia just anterior to it is the fascia iliaca. So this will extend to cover the posterior aspect of the femoral vein and the femoral artery as they enter the thigh, the front of thigh, forming the posterior wall of the femoral sheath, the fascia iliaca. Can you tell me what is this structure? The femoral nerve. So the femoral nerve, it lies in front of iliacus muscle, but behind the fascia iliaca, not in front of fascia iliaca. The femoral vein and femoral artery, which lie in front of the fascia iliaca, behind the fascia transversalis, they are enclosed within the femoral sheath. But the femoral nerve, which lies behind the fascia iliaca, it lies outside the femoral sheath, right? It is not getting any facial prolongation to cover it. And what is the purpose of this femoral sheath? So during movements of the hip joint, these vessels, they have to glide right behind the inguinal ligament in and out. So to prevent friction, they have a facial prolongation called the femoral sheath. So we saw that the anterior wall is by fascia transversalis and the posterior wall is by fascia iliaca. Similarly, you can see there is a lateral wall. This lateral wall is more vertical. And a medial wall. The medial wall of this femoral sheath is more oblique. It is pointed downwards and laterally. And then there are two anteroposterior septa extending between the anterior wall and posterior wall, dividing it into three compartments from medial to lateral. We have a medial compartment, we have an intermediate compartment, and we have lateral compartment. Yes, can you tell me what are the structures present in each compartment? In the lateral compartment, we get to see femoral artery, and you can see one small nerve accompanying it. Yes, come on, very good. That's the femoral branch of genitofemoral nerve. This femoral branch of genitofemoral nerve, it will pierce the anterior wall of femoral sheath, that is the fascia transversalis, to supply the skin over the femoral triangle. Root value of genitofemoral nerve, L1, L2. Okay, and in the intermediate compartment, we get to see the femoral vein. In the medialmost compartment, which we'll be talking in detail in another few minutes, it's called the femoral canal. As you see here, there's one lymph node. We have the deep inguinal lymph node. This one is called the node of Cloquet. So this has the node of Cloquet and the loose areolar tissue. The purpose of the medial compartment is to provide a dead space for the expansion of the femoral vein during increased venous return. Okay. So as you see here, the lateral compartment has the femoral artery and the femoral branch of the genitofemoral nerve. The intermediate compartment has one structure, the femoral vein, and the medial compartment literally has nothing, just the lymphatics and the lymph node, the node of Cloquet or the Rosenmuller. Okay. Yeah, this is a high yield topic. Lot of MCQs, image based questions come from it. Now let us move on to the femoral canal. That is the medialmost compartment, right, of the femoral sheath. It measures 2 centimeters in length. It is conical and the base of the cone is pointed upwards. It forms the femoral ring through which the abdominal contents can enter, producing the femoral hernia. So this femoral ring is the communication between the abdominal cavity and the thigh. Okay. So as I told you, it has the deep lymphatics, the node, the deep inguinal nodes, right? Especially the node of Cloquet or Rosenmuller and the loose areolar tissue. It provides a dead space for expansion of the femoral vein. Okay, that is the purpose of this femoral canal. So we saw that the femoral ring is nothing but the base of the femoral canal, right? and the boundaries of it are very important. It is bounded anteriorly by the inguinal ligament. Okay, the inguinal ligament, it forms the anterior boundary of this femoral ring. And posteriorly, yes, in the femoral triangle, what are the muscles from lateral to medial? Iliacus, psoas, pectineus, and adductor longus. So the fascia covering pectineus muscle, it forms the posterior relation for the femoral ring. This is a femoral ring, right? So medially, you see one important structure that an extension of the inguinal ligament, it's called the lacunar ligament. Very important, okay? So the medial boundary of this femoral ring is formed by lacunar ligament, and laterally we have the septa that separates this femoral canal from the femoral vein, which lies in the intermediate compartment. This femoral ring, I told you, it is going to be the communication between the abdominal cavity, right? And it is close by femoral septum. This femoral septum is nothing but a condensation of the extraperitoneal connective tissue, right? And there is a depression above it called the femoral fossa, a peritoneal depression, right? Okay. So that's about the femoral ring, the femoral canal, femoral septum, and the femoral fossa. Now, yes, this femoral ring in female, it is considered to be wider because the female, they have a wider pelvis, and also the femoral vessels, they are of smaller size. All these factors make femoral hernia more common in female, right? But please understand, this was a recent NEET PG question asked, right? Inguinal hernia is common in female, right? And femoral hernia compared to male, it is common in female. The reasons are because of a wider pelvis, a wider femoral ring, and smaller size of the femoral vessels. So you see a bulge here, the front of the thigh. So below and lateral, okay? So this is the pubic symphysis. Here you'll have the pubic tubercle. Below and lateral to the pubic tubercle, below the inguinal ligament, suggestive of femoral hernia. So what is this femoral hernia? Abnormal protrusion of the intestinal contents, okay, through the femoral ring. Yeah, abnormal protrusion of the intestinal contents from the abdominal cavity, right, into the femoral ring, a weaker part of the abdominal wall. So it is located, yes, as you see here, in the front of thigh, below the inguinal ligament, below and lateral to the pubic tubercle. If in case it is an inguinal hernia, please remember it is going to be situated above the inguinal ligament, right, above the pubic tubercle. So the cause of the femoral hernia, we saw that the intestinal contents, they herniate into the femoral ring, right? And they'll pass downwards into the femoral canal. So, yes, relation of the saphenous opening. Can you appreciate the saphenous opening here? So this is the upper lateral and the lower margin of the saphenous opening actually lies in front of the femoral vessels, whereas the medial margin, ill-defined, it goes behind the femoral vessels. Okay, so the femoral hernia, through the femoral ring, it descends down into the femoral canal and then it turns forwards. Okay, it comes out through the saphenous opening, and then it proceeds upwards, right, along the falciform margin of the saphenous opening towards the inguinal ligament, downwards, forwards, and turn upwards. So this is the course of the femoral hernia for reduction. The reversal is done. Okay. Another important point related to femoral hernia. Can you tell me what is this pointed structure? This is the inguinal ligament. Where is our femoral ring here? So this is the lateral compartment of the femoral sheath which has the femoral artery. This is the intermediate compartment which had the femoral vein, and the medialmost one, this was the femoral canal. Its upper margin, the base, we call it as the femoral ring, right? And medially it was bound by the lacunar ligament. In the lacunar ligament, there is an anastomosis between the pubic branch of obturator artery and the pubic branch of inferior epigastric artery. A chocolate question, can any one of you tell me? This inferior epigastric artery is a branch coming from, yes, external iliac artery. Okay, you people tend to forget it again and again and again. The external iliac artery will give rise to two branches, the deep circumflux iliac artery and the inferior epigastric artery. So over the lacunar ligament, there is an anastomosis between the pubic branch of obturator artery and the pubic branch of inferior epigastric artery. Okay, and sometimes one of these pubic branch can be abnormally enlarged, right? And during surgical management of this femoral hernia, they widen this femoral ring. They have to cut through the lacunar ligament, and accidentally, if this pubic branch is going to be abnormally enlarged, it will lead to severe hemorrhage. Hence, this anastomosis is called corona mortis, a very dangerous anastomosis. Okay, so if one of these pubic branches is going to be abnormally enlarged, we call it as the abnormal obturator artery, that can lead to severe hemorrhage. While do a surgical incision of the lacunar ligament during widening of the femoral ring in femoral hernia surgery. Okay, so that was about the femoral sheath and femoral hernia. Now we are moving to the last component of this session. A 17-year-old Mr. Sam, a porter in the railway station who neglected wearing footwear most of the time, got his left leg injured 10 days back. Later, he developed a small swelling at the back of his left knee. So far, we have been reading swellings related to the front of the thigh, right? Here, there's a small swelling back of his left knee in the popliteal region, right? He ignored it, though it gave some pain. For past 2 days, he noticed that few more swellings appearing in his left groin. So in the popliteal and then in the inguinal region, yes, the lymph nodes. So we have the lymph nodes in the popliteal region, also lymph nodes in the inguinal region, and they drain the lower limb, the different parts of the lower limb. Let us look into it. So the superficial inguinal lymph nodes, they lie above the deep fascia. They drain the, yes, the skin and the subcutaneous tissue of lower limb. And they are arranged as two groups. Upper group, the one that you see here, upper horizontal group, and a lower vertical group. Okay. This upper horizontal group, you can see it like it around 5 to 6 nodes arranged below the inguinal ligament. Okay, a group of nodes lying along a chain below the inguinal ligament. And the vertical group, they are placed on either sides of this great saphenous vein. Okay, let us see the afferents of these groups, right? So this upper horizontal group is further divided into upper medial and upper lateral. This upper medial group, it is going to receive afferents from the anterior abdominal wall, the skin and subcutaneous tissue of the anterior abdominal wall below umbilicus. Okay, so imagine this is the umbilicus, this part of the area, right? And then this is the penis, and behind that you see the scrotum, and even further behind we'll come across the area called perineum. So in the perineum, okay, the anterior part of the perineum is called the urogenital triangle, okay, and the posterior part of the perineum is called the anal triangle. So the structures related will be there present in the perineum. Now, the upper medial group is going to receive lymphatics also from the skin of the penis, including prepuce, but not glans penis, and also from the scrotum in male. In female, it will be the vulva and vagina below hymen. Okay, and the upper medial group, it also receives the lymphatics from the skin of the perineum and the anal canal below the pectinate line, the terminal most part of the urethra, okay, and the uterine lymphatics that accompany the round ligament of uterus. Okay, so the upper medial group is very important. Normally, lymph nodes are not palpable. When do they become enlarged? When there is an infection or there is some malignancy in the area drained by those group of lymph nodes. So if there's going to be an inflammation in the skin of the penis, as seen in syphilitic lesion, the upper medial group can go for enlargement. Okay. And coming to the upper lateral group, so this will also receive lymphatics from the anterior abdominal wall below the umbilicus and also from the gluteal region. So any abscess in the gluteal region, then the upper lateral group of lymph nodes can go for enlargement. The lower vertical group, which is arranged along the great saphenous vein, it receives the lymphatics that accompany the great saphenous vein from the lower limb. Okay, so all the superficial lymphatics from the lower limb that accompany the great saphenous vein, okay, will open into the lower vertical group, except those lymphatics that accompany the short saphenous vein will drain into the popliteal group of lymph nodes. So the great saphenous vein, it begins as the continuation of the medial end of the dorsal venous arch. So most of the foot, including the great toe, the second, third, and the fourth toe, will be accompanying the great saphenous vein, whereas the little toe and the lateral border of the foot, the part of the back of the leg along the lateral aspect, will accompany the short saphenous vein to drain into the popliteal group of lymph nodes. So there's an infection of the great toe, then which group of nodes will go for enlargement? The upper vertical group. If there's an infection of the little toe or the lateral border of the foot, then the popliteal lymph nodes will be enlarged. Now, let us do the deep inguinal lymph nodes. So, the deep inguinal lymph nodes are situated deep to the deep fascia, and they are present in relation to the femoral canal. They drain the deep tissues, the whatever that lies deep to the deep fascia, and accompany the deep veins, right? The femoral veins, all that. And especially glans penis will drain into the deep inguinal lymph nodes. The superficial inguinal lymph nodes, okay, their efferents will pass to the external iliac lymph nodes. Similarly, the efferents from the deep inguinal lymph nodes also will pass to the external iliac nodes. A few lymphatics from the superficial inguinal lymph nodes can drain into the deep inguinal lymph nodes. Usually, there are 3 deep inguinal lymph nodes. One at the junction of the great saphenous vein with the femoral vein. The second one, the node of Cloquet in the femoral canal. And the third one in the femoral septum, right? So this is the one at the junction of great saphenous vein with the femoral vein. This is the node of Cloquet in the femoral canal, and this one in the femoral septum. Okay, so please remember the skin of the penis, including the prepuce, that drains into the upper medial group of superficial inguinal lymph nodes. Whereas the glans penis, a carcinoma of the glans penis, yes, will involve enlargement of the deep inguinal lymph nodes, the one in the femoral canal. And popliteal lymph nodes, I told you, right? Little toe and the lateral border of the foot. The great toe and the other toe, yes, are the lower vertical group of the superficial inguinal lymph nodes. So I'll read this case scenario again. Yes, we have come to the end of this session. So this session we started with this case scenario, right? A 21-year-old Mrs. Chaitra presented to surgery OPD with complaints of swelling over the front of the right thigh, fever for past 5 days, backache because of the tuberculosis of spine, difficulty in walking due to the presence of the swelling in the front of the thigh, cystic swelling below the inguinal ligament. Okay, confirm the diagnosis of psoas abscess. So how is the psoas muscle related to the front of the thigh? So this psoas major muscle, you can see it lies on either side of the vertebral column. You can see the lumbar vertebra here, L1, L2, L3, L4, L5. This psoas major, it originates from the anterior surface of the sides of the bodies of the lumbar vertebra, from the intervertebral disc lying between these bodies, and from the anterior surface of the transverse process. Okay, you can see the muscle going downwards, right? It goes behind the inguinal ligament to insert into the lesser trochanter of femur. It forms the floor of the femoral triangle. We can see it in the floor of the femoral triangle, just medial to iliacus, right? And there's a fascia covering this psoas major muscle. It's called the psoas fascia. So when there's a tuberculous inflammation of the lumbar vertebra, the abscess formed can track between the fascia covering the muscle and the muscle, right? So, and we know the muscle reaches all the way up to the front of the thigh, the upper thigh. So this abscess can lie beneath the fascia, psoas fascia that covers the psoas muscle, and reach the upper part of the front of the thigh, forming a swelling there called the psoas abscess. This psoas major is receiving its innervation from the lumbar plexus, direct branches from the lumbar plexus. The iliopsoas is the chief flexor of the hip joint. Let us work out few MCQs. Which of the following branches of femoral artery is not given off in femoral triangle? Yes, the descending genicular artery is the last branch coming from femoral artery, and it is given off in the adductor canal. Okay. Which of the following pointed structures is not innervated by femoral nerve? Yes, you can help me identify. A is sartorius, that is innervated by a branch coming from anterior division of femoral nerve. B is iliacus. Iliacus is innervated by a branch coming from the trunk of femoral nerve. Nerve to iliacus, nerve to pectineus, and vascular branches arising from the trunk of femoral nerve. C is rectus femoris of quadriceps femoris, that is innervated by nerve to rectus femoris coming from the posterior division of femoral nerve. D here is, come on, it forms the medial border of the femoral triangle, right? Adductor longus. It is a muscle of the medial side of the thigh that is innervated by obturator nerve. Got it? Yes. So that is not innervated by femoral nerve. A 40-year-old male 3 months ago started to feel a bulging lesion on the surface of glans penis. Known smoker for 20 years. No multiple sexual partners and no viral infection. Patient was circumcised. He started having difficulty in micturition. He went to the surgery OP. The glans penis was fully covered and invasion was detected in the urethral meatus. Biopsy was taken and urethral meatus was opened. The biopsy result was squamous cell carcinoma. So carcinoma of the glans penis. Which group of lymph nodes enlarge? The deep inguinal lymph nodes. The medial members of the upper horizontal group of superficial inguinal lymph nodes, they receive from the skin of the penis, including the prepuce, but not the glans penis. A 24-year-old female in a vegetable market entered into a quarrel with her drunkard husband. During the brawl, she received a deep knife wound to the front of her left thigh. After a thorough examination in the emergency department of the local hospital, it was determined that the knife point had severed the trunk of right femoral nerve. So if the trunk is cut, then yeah, the further branches are also involved, right? Identify the incorrect statement. Skin sensation was lost over the anteromedial aspect of the thigh. Of course, the intermediate and the medial cutaneous nerve of thigh. Coming from the anterior division of femoral nerve. Skin sensation was lost along the lower lateral aspect of the thigh. No, why? The lateral cutaneous nerve of thigh with the root value L2, L3 is coming from lumbar plexus and is not a branch of femoral nerve. Skin sensation was lost on the lower part of the leg, medial border of the foot as far as the ball of the great toe. It is the territory of the saphenous nerve. And saphenous nerve, we know it's a branch coming from the posterior division of femoral nerve. The right quadriceps femoris muscle failed to contract. Of course, it is innervated by the femoral nerve. The branches to the quadriceps femoris, they arise from the posterior division of the femoral nerve. So the incorrect statement will be B. The femoral ring is bounded by the following structures. The inguinal ligament will form the anterior boundary, lacunar ligament will be the medial boundary, and the femoral vein related lateral to it. Okay. The femoral artery is not a boundary for the femoral ring. It lies as the content of the lateral compartment of femoral sheath. A 70-year-old lady was admitted in the emergency department for complaints of abdominal pain and frequent episodes of vomiting. She complained of a swelling in the right groin, 3-month history. And the swelling had become painful 24 hours prior to admission. On examination, the abdomen was distended with loud peristaltic sounds. The groin swelling was diagnosed as femoral hernia. Which of the following statement is not true about this groin swelling? So femoral hernia is more common in females. Yes, you can tell me because of the wider pelvis, wider femoral ring and smaller size of the femoral vessels. Abnormal obturator artery can be injured during the repair because it lies over the lacunar ligament that forms the medial boundary of the femoral ring. This swelling is located below and lateral to the pubic tubercle. The femoral ring is bounded behind by the pectineus muscle is of course right. Okay. Anterior wall of the femoral sheath is formed by fascia transversalis. Femoral nerve, it lies outside the femoral sheath. Okay. So in this session in lower limb, we have seen about femoral triangle, details about femoral triangle. So where is it located? What are the boundaries and its contents? We started about talking about the boundaries, right? The medial border, the lower border, the base and the apex and the flow structures, the roof. In the roof, we talked about the cutaneous innervation of the thigh. Remember, what is meralgia paresthetica? Yes, compression of the lateral cutaneous nerve of the thigh. We saw about cremasteric reflex. Cremasteric reflex, what is its root value? L1 and L2. And then we moved on to talk in detail about the femoral vein. Yes, its formation, termination, extent and tributaries. Femoral artery is what is it a continuation of? What is its extent? And then what are its branches? What is the largest branch of femoral artery? Can you tell me? Profunda femoris artery. We then talked about profunda femoris artery also, right? The perforators, the anastomoses, cruciate anastomosis, the trochanteric anastomosis related to the branches of profunda femoris artery. Okay. Then we talked about the femoral nerve, the trunk, anterior division and posterior division. Can you tell me what structure passes between the anterior division and the posterior division of the femoral nerve? Yes, come on. The lateral circumflex femoral artery. Okay. And then about the femoral sheath. Only if you understand femoral sheath, you can understand femoral hernia, which is very important. And lastly, about the superficial and deep inguinal lymph nodes and all the clinical anatomy related to the contents we have seen. Hope this session was interesting and useful. Thank you.